Thank you for joining us for today's program on assembling non-physician providers in your practice. I'm Terry McWilliams, the director in the HSG and also the Chief Clinical Consultant. Just need to address a couple of housekeeping items before we start the presentation. If you haven't already done so, you can download handouts for today's presentation via the link emailed to you in the registration reminder. If you do not have that link handy, you can access the handouts on our website page that's been established for the webinar at hsgadvisors.com. From the home page, scroll to the bottom and click on Webinars, then select the listing for this webinar for access to the handouts. If you have difficulty downloading the handouts, please send us an email at info@hsgadvisors.com. We welcome your questions, and you can submit them at any time during the program by using the question submission option on the right panel of your screen. We will answer the submitted questions at the end of the presentation without identifying the names or affiliations of those who submitted them. If you submit a question and we cannot get to it during today's program, we will be sure to answer it promptly via email. Also, after the broadcast, you're welcome to reach out to me at any time through the contact information provided here on the screen and in the handout. So with that behind us, let's go ahead and get started with today's program by reviewing our objectives. So by the end of this presentation, we hope that you'll be able to recognize trends in provider supply and the impact of that supply on care delivery models, that you would understand the potential benefits of incorporating non-physician providers into practices, while appreciating potential barriers to incorporating them and considering mechanisms to successfully integrate them into practices and fully utilize their skills and capabilities. For this webinar presentation, we're going to be very specific in our use of the term non-physician providers. We'll focus primarily on APRNs, advanced practice nurses, and PAs. And we'll not talk about other groups of non-physician professionals, especially those in the behavioral health realm and in other initiatives. So that's going to be primarily the focus of our conversation today. So I don't think it's any surprise to anyone attending this presentation that the background shows a growing physician shortage, where the demand for health care is outstripping the current and projected future physician capacity to meet those needs. If we look at the most recent Association of American Medical Colleges projections released just a few months ago, the projected shortfalls by 2025 will reach upwards of 80,000 physicians, and by 2030 upwards of 105,000 physicians. These numbers are actually attenuated a bit based on incorporation of assumptions that APRNs and PAs will be assimilated into the care delivery model and attenuate the shortage. So these numbers actually presuppose that some of the shortage will be met by assimilation of the NPPs and practices. A lot of the data would indicate the primary care will be affected more than other specialties, but specialties and subspecialties across the board will be impacted by the shortage. Feeding into this is the supplies of NPs and PAs is growing at a much more rapid rate than the physician supply. This is in part due to shorter training cycles and also in part due by heightened interest by applicants fueled by the increased demand for the services and the fact that this anticipated to be a high demand career opportunity. This is a very busy curve. It's actually from that AAMC study. But basically the top four curves are the demand, projected demand for physicians. These are attenuated by the fifth and sixth curves, which shows the attenuation based on APRN and PA incorporation in the practices. If we go down to the main supply curve, which is the heavy dark black dotted line, that would be the supply if we followed status quo. The upper limits of supply with the dot dash blue would be if physicians retired 2 years later than anticipated, and the lowest line would be that if physicians retired 2 years earlier than anticipated. There is some attenuation based on the current economic circumstances, and that physicians are retiring a little bit later based on economic uncertainty, and that's balanced by the retiring earlier because of EMR implementation and MACRA and other things that are impacting the desire to stay in practice. There are other factors that the study considered, such as expanding GME. What if all physicians adopted the, quote, millennial hours, which actually are predicated on the, the change in 80-hour residency work week, and the impact that the desire to work less hours than perhaps predecessors had worked. So you can see that the supply and demand are all over the map, but clearly there's a big delta between supply and demand no matter which projection is utilized. We contrast that with nurse practitioner growth, which on the bar graphs through 2012 shows a significant uptick. And if we look at the total licensed NP capacity, it nearly doubled in that 10 years from 2004 to 2014, going from 106,000 up to 205,000. However, if we look at the total numbers, that 205,000 compared to the numbers of physicians on this slide of upwards of 800,000 at the same time frame, there's clearly not a one-to-one dimension in that regard. PA growth shows a similar curve, and the total number of certified PAs grew almost 50% in 6 years, from 2010 to 2016, going from 80,000 to 115,000. So clearly significant growth in both NP and PA supply that seems to be outstripping the growth of physician supply and being looked at as a mechanism by which we can meet healthcare demands of the population. So with that, the AAMC report indicated that a fall in the physician to PA ratio by about a half, from 7.2 to 3.5 over the next 15 years, and the physician to APRN ratio similarly from 3.6 in 15 to 1.9 to 1 in 2030. People wonder about, well, okay, it's just to meet a supply and demand issue, right? But frankly, there are benefits to integrating NPPs and practices that go beyond that. So part of this is going to be predicated on a supply and demand issue, but some of this is also predicated on other facets, making use of the NPP's unique skill sets, for instance. So we'll go down each of these in turn and discuss just a little bit. Now, of course, the discussion won't be all-inclusive, but hopefully will give us an idea of some of the benefits of NPP inclusion. So the enhanced access issue, both in primary care and other specialties, allows more timely patient access. If we look at primary care, there are estimates in the literature that indicate that NPs should be able to perform approximately 85% of primary care tasks, NPAs approximately 80%, and studies have indicated comparable quality and lower cost in providing the care. Targeting areas such as preventive care and wellness, office-based acute care, and managing patients with stable chronic conditions tend to be their niche. And adding NPPs in that setting tend to be able to be done in a cost-effective manner, and as each of these individuals are highly productive, which we'll talk about in a minute. In other specialty care, the direct patient care opportunities include performing initial assessments, providing follow-up care and following through on the plan of care regimen, and performing specific procedures, which are especially specific areas. It's been postulated that NPP integration can actually expand a practice's capability, and they'll play significant roles in a lot of the value-based care delivery models that are out there, especially those emphasizing team-based care, as opposed to those that emphasize an independent NP, for instance, opening up his or her own practice in a solo arrangement. But the education and training curricula ideally suit these individuals to provide services that are key to value-based care, such as a focus on preventive and wellness services required for enhanced population health management, care management and care coordination services, patient education both on a one-on-one basis and in group settings, and actually entailing greater patient engagement in their care and greater patient engagement in the practice environment as well. Again, the data would indicate same quality of care at less cost, which is a key issue when we talk about the value equation. The one other area to mention, and this is a specific example, but their presence can actually expand the scope of services rendered by a practice. This is particularly notable in an OB practice that incorporates certified nurse midwives, because you can reach a population that you may not have been reaching before based on the type of service provided by the midwife compared to an obstetrician. There are many more examples, but that just seemed to be the most readily apparent. Patient satisfaction across the board tends to be enhanced in NPP interactions with patients, and they do it in two ways. The first is directly with satisfaction with the care the NPP provides, but also indirectly with enhanced access to the practice. So in expanding same-day access, for instance, or having more direct care providers dealing with patients, the enhanced access leads to increased patient satisfaction and also the individual interactions. As a group, the NPPs tend to be very patient-centric. They interact with patients on a different level than physicians most often, and they are very successful in engaging patients in their care. In practices that have successfully incorporated NPPs, these individuals tend to develop a following of patients in the practice who preferentially request the individual in scheduling. And again, focusing heavily on patient education, ensuring the patient understands the plan of care, exploring barriers to care, and following through very well. There are studies that indicate that practice productivity increases when NPPs are incorporated in the practice and utilized at the top of their license and capability, both in direct patient evaluation and treatment, but also in performing procedures that free the physician members of the team to provide other care. Some of these are listed here just as examples, but an NPP performing any of these would then allow the physician in the practice to assume other interventional or care-related activities. The 2017 MGMA Data Dive Cost and Revenue Survey demonstrated very clearly that practices that had a higher NPP to physician ratio earned more revenue after operating costs than practices with fewer. This shows, again, the cost effectiveness of incorporating these individuals into practice. There is a caveat with this that I would emphasize, and that is the NPPs must be experienced and must be used at the top of their licenses and capabilities. NPPs are utilized as scribes or as other than individuals who can utilize the full extent of their capabilities will not see these results, but those practices that utilize them at the top of their capabilities do show enhanced revenue generation. So with all these good reasons to incorporate NPPs in practices, why don't we? And routinely, although there are many reasons, routinely we tend to come up with these three notable exceptions. One is physician acceptance, second is patient acceptance, now not so much an issue, which we'll talk about in a second, and then regulatory and institutional requirements, which may restrict utilization. On the physician side, I'm continue to be amazed at how many physicians have never worked with an NPP and therefore lack a positive personal frame of reference. I say I'm amazed because in my background, in both my training and practice, was very intimately exposed to NPPs across the board in many settings, and all of my interactions have been positive. These individuals clearly had excellent training, were very open to mentoring and furthering their expertise, dealt well with colleagues and dealt well with patients, and were very well received across the board. Another barrier is the opposite. There was experience with an NPP and it led to a negative personal frame of reference. In this instance, it could be a mismatch between the expectations that the physician had and the realities of the situation, whether on a general or specific basis. And ironically, it could be a matter of either over zealous autonomy or inadequate autonomy. So what I mean by the latter case, if an NPP has not been intimately involved in a patient's care but is expected to communicate issues, there can be a disconnect, and the NPP can appear to have a lack of expertise or a lack of a competency, so to speak, when in essence it's just a lack of involvement and not being intimately involved in the patient's care, yet trying to convey information about it. On the other hand, there are instances where NPPs were placed in a situation where they were fully autonomous early in their careers and maybe got in a little bit over their head, and in reaching out for assistance, the inexperience may have shown, and that could have created that negative personal frame of reference. There's also the perception that NPP education and training is, quote, inadequate, end quote. Individuals can point to a short duration of formal education, which traditionally has been a two-year master's level program, and the lack of postgraduate training. On counterbalancing the issue on the formal education program is that many NPPs have a healthcare background and entered their postgraduate, or excuse me, the graduate level training already having a significant background in healthcare. This is especially the case for APRNs, where traditionally the RN functioning in a clinical environment received a great deal of experience and expertise, and subsequently sought the graduate degree to become more clinically involved as an APRN. These individuals had an undergraduate degree full of healthcare information and education, backed by a number of years of practical expertise going into their graduate level degree. Some of this is getting a little bit less notable as more and more RNs are going into the APRN realm very soon after their undergraduate training. The postgraduate training, much of the curricula for NPs and PAs have a tremendous emphasis in primary care, especially for the NPs. And coming out of their educational program are very much, very well trained for primary care positions, but still require mentoring on the job, very much like residency graduates, and making the transition from resident into junior attending. On the specialty side, specialties other than primary care, I should say, there could be significant need for on-the-job and potentially additional didactic education to function very well in a specialty or subspecialty environment that's a little bit different than the curricula. Of course, PAs are educated on medical model, have what would amount to a very broad, rotating experience, but still may not have the in-depth knowledge required to function relatively autonomously coming out of their educational program. And then we already talked about too little or too much autonomy, especially early on, potentially being a a perceptual barrier or contributing to a negative perception of the NPPs. As far as patient acceptance, maybe 20 years ago, patient acceptance was a higher consideration, but most patients have encountered NPPs during their healthcare interactions over the last decade for sure, and this barrier is now limited to small pockets of patients. Multiple surveys and studies have indicated patients are very accepting of NPPs, and like any provider, NPPs who deliver empathetic, compassionate, quality, however that's defined, care are readily accepted and embraced by the patient population, and as mentioned before, quickly develop a loyal following. External requirements between state regulations, laws and regulations, and medical staff bylaws clearly represent a barrier to full utilization of NPPs. States determine the degree of independence that NPPs can exercise. Uniformly, at least at the present time, all states require physician supervision of PAs. There are many, including the national organization, that advocate more independent practice or looser but effective supervision, but at the present time, all states require supervision. For APRNs, it varies by state. There are 19 states as of August of last year that permit independent NP practice, and 17 states permit independent CRNA practice, again as of August of 2016. The independent CRNA practice is based on a CMS physician supervision waiver that's been available since 2001, but states must apply for and be granted the waiver. And you see this occurring in states with significant rural care needs, because this is a huge deal in the rural environment to have CRNAs be able to practice relatively independently of supervision. The other barrier, especially for employed practices or system-employed practices, are medical staff bylaws. The bylaws tend to be more harsh and more unduly restrictive of NPP clinical privileges, regardless of the state regulatory requirements. And again, part of this is what I am phrasing based on archaic beliefs that have been perpetuated, often due to a negative frame of reference, with the physician barriers we talked about just a minute ago. This perception of NPP restrictiveness within the hospital setting translates into and impedes NPP integration in the hospital employed practices and full utilization of the NPPs on the inpatient side, unfortunately. The bylaws restrictions are starting to change a little bit, but still represent a fairly significant impediment in many areas. So if we want to integrate NPPs into our practices, how should we go about it? The quote best way might be first planning the change, define the problems being addressed and the desired goals to achieve, then looking to outline potential alternatives to achieve the goals, and then define how the NPP integration could address the problem. Explore the practice culture to discover barriers to NPP utilization, and actually conduct a failure modes and effect analysis with the staff to identify and proactively rectify operational implications of NPP utilization. In the process, we should develop a compensation plan and define incentives, ideally consistent with those of the physicians in the practice. Once the integration is planned, it becomes a matter of timing. The most appropriate timing will depend on the underlying issue to be addressed. If it's an issue of demand for services exceeding capacity, that might be a little bit more urgent. It could be associated with adoption of a value-based care delivery model, which might be more deliberate, or might be part of a care management and care coordination program as well. Recruiting the candidate, clearly you have to have a desired skill set, both on the clinical and interpersonal sides. find an individual that agrees with the conveyed plan and that would embody a cultural fit both in the practice and in the community. Once an ideal candidate is recruited, it's imperative to effectively onboard the new hire, both on the administrative side with third-party payer credentialing, medical staff credentialing, and office-based logistics, and also collegially to ensure that the individual feels welcomed into the practice and welcomed into the community. Both of these start shortly after getting a signed contract. Once on board, it's a matter of executing the integration plan, monitoring the progress of the plan, and adjusting accordingly. Throughout that process, staff might need to be held accountable to make sure that the plan is being executed as desired. Most notably, that the individual is being utilized to the top of their capabilities, and that the progress is steady and being maintained. So if we do all of this, what kind of outcomes can we expect? And in developing this, we thought that it might be best to just show some examples in various specialties and various circumstances that might demonstrate the positive return that individuals have experienced when incorporating NPPs. The first example is an orthopedic practice. This is a practice that consisted of 3 orthopedic surgeons, one of which had a PA. And the orthopedic surgeon with the PA was requesting advice of how to best utilize the PA. This was part of a larger project, but this was a keen interest on both the part of the employed group, but also this particular surgeon. And the surgeon was having difficulty utilizing the PA. There was one schedule, it was under the surgeon. They kind of saw the patients together, and essentially the PA was more of a scribe and medical assistant during the interactions, and neither the surgeon nor the PA were feeling very professionally fulfilled. At the same time, the practice was considering hiring a cast tech, and this orthopedist in particular was feeling it because he was doing a lot of cast work and he was the cast tech. So when he was doing casting and splitting, other things weren't getting done, and he was just feeling frustrated across the board. So the advice rendered was to hire actually a second PA. And while that sounded a little bit counterintuitive, especially to the surgeon, he said, wait, I don't know how to use one, and you want me to hire a second. That just doesn't seem to make sense. And so when we explained how it might make sense, he was won by that presentation, and I'll just explain here briefly what we envisioned. So rather than scheduling the patients with the surgeon and having the PAs fill in, we recommended that the schedule actually be the PAs, the individual PAs. So have 2 schedules functioning all day long in the office with alternate patient arrival times, and adequate time to complete each encounter, and altering the schedule to allow same-day access. This was particularly important for ED follow-ups, but also an issue for self-referrals. The practice was very tight in getting patients in because of the high demand for their services, and we felt this offered the opportunity to also permit greater same-day access to the practice. So each PA would have their own schedule and their own set of exam rooms, and the orthopedist and each PA would then evaluate the patient. The orthopedist would then see each patient after the PA evaluation, and the PA would complete the visit, patient education, etc. And then the surgeon would go to the next, to the other, and also be able to incorporate prescription refills and telephone consults and other points of business in between, going back and forth. So essentially we created 2 full schedules of patients covered by a single orthopedic surgeon, which significantly enhanced patient access to the practice and allowed both the PAs and the surgeon to feel more professionally fulfilled. The next was to train the PAs in splitting and casting techniques with the recommendation to have them attend a formal hands-on course followed by on-the-job mentoring so the orthopedic surgeon can ensure that the PAs knew his personal tendencies for both casting and splitting. This became a skill that was applicable not only in the office but in emergency department responses, on the inpatient unit, and in the operating room. On the surgeon's OR days, we felt that the PA having two PAs would be twice as beneficial to the surgeon, and that one PA would be in the case while the second PA was available to perform the perioperative assessment, like updating the H&P and addressing any issues that arose, and also be available to triage or address issues from the office, the emergency department, and the inpatient unit. While a PA may not have been able to fully address and resolve the issue, it would at least have allowed an initial call and then follow up with the orthopedic surgeon between cases. The PA that was in the operative case would stay with the patient through the end of the case and the initial post-operative interval, including entering the templated orders, while the surgeon and the second PA moved on to the next case, which the second PA had prepped and is familiar with, and then the roles would reverse. Even without double rooming, this created great efficiencies for the surgeon, who was very happy with the change. And I might add, so were the people that would call the surgeon during a case and not be able to get in touch with the surgeon. So this was a very satisfying change, not only for the orthopedic surgeon, but also for those who were interacting with him on a regular basis. So the anticipated outcomes from this intervention were professionally fulfilled orthopedists and PAs, enhanced patient access, increased practice revenue, which outperformed the increase in expense, and missing on this is global satisfaction from all those involved. So a little bit unique, a little bit different, but allowed everybody to function at a higher level. Another example was two cardiologist practice that had various in-office services, including stress testing capabilities. They were unable to meet demand for their services. They were a very good group, and they were located in a place that was just a difficult recruitment. So getting a third cardiologist was not working out well for them. They actually approached wondering about hiring an NP. And would that make sense? And if it did, how could that help them? And so what we had suggested was to offload the in-office stress testing. So the cardiologist would conduct a screening, determine the patient needed the stress test, and then the NP would perform the stress testing pretty much all day long at the start because of the backlog. This freed up the cardiologists immensely because they were the ones conducting the stress test in the past. And so it essentially created for scheduling purposes, created a whole new individual FTE schedule. We also found that or recommended that the NP, when not performing stress tests, conduct patient education related to the conditions that patients were experiencing, especially newly diagnosed individuals, and engage these individuals in secondary and tertiary prevention efforts. Now, technically, these latter two things could also have been done by an RN, so back to utilizing people at the top of their license. One of the things we talked to the cardiologists about was in the future, considering hiring an RN to take care of these situations, work with triage, and then allow the NPP, moving down to the next, more direct patient care responsibilities, and especially if once this model was working well, expanding to include a second NP, and expanding utilization both in the office setting but also the inpatient setting for new consults and follow-up patients. We worked with the cardiologists through the incorporation of the first NP. They did intend to hire a second and then we're just going to do the RN third as opposed to RN before the NP. However, the practice did experience enhanced patient access. The cardiologists were ecstatic about the role that the NPs played, and again, they experienced an increase in practice revenue that outperformed the increase in expenses with a new staff member. A third example actually is in primary care, and in this instance, it was a health system-owned solo family medicine physician practice in an underserved rural health profession shortage area. The practice experienced a 3-month wait time for new patient appointments, and the practice's productivity exceeded the 90th percentile. We have at the, but it was actually above the 90th percentile, significantly above. So the physician was working hard, and the demand for services just really outstripped his ability to provide the services. The system had been trying to recruit a family physician to join him for 2 years, and had been unable to do so. And pushing this a little bit further, the system was part of a clinically integrated network that had signed to be an MSSP type 1 ACO, and with MACRA and everything else, they were anticipating assuming greater financial risk and either going to a different level type 2 or 3 MSSP program, where actually they were more likely considering going to the next generation ACO model. So there was a lot more pressure for the practices to perform well. So again, part of a larger project, but in this instance, especially with the ACO involvement, we had recommended exploring the PCMH care delivery model to serve as a framework for clinical practice transformation and incorporation of an established NP within the practice. Recruitment did lead to hiring an NP with a skill set and cultural fit to match utilization. The rural environment was a key element, and the NP actually had been an RN in the region for quite a while, and was, I think, 2 years out of completing her master's program, and was looking to return to the area. So it was a good match from in that regard. Initial incorporation of the NP focused on providing same-day access and preventive wellness services, which helped across the board and took a lot of pressure off the family physician, but it was an excellent fit. Sorry, I need to go the right way. In looking at the ACO environment and what the system was doing, the system assisted with hiring an experienced RN to help with care management elements. And this also freed up the physician, especially because we had the RN starting to do the Medicare initial preventive physical exam, or the Welcome to Medicare visit, and the Medicare annual wellness exams, which the practice was trying to do, but again, it was clogging up the FP schedule. So we unloaded those and enhanced the program a bit, had the RN start conducting these, and as far as cost effectiveness, conducting just 2 of the annual wellness visits per day covered her compensation, and does so in most areas of the country. Some areas of the country might need to have 3, but in this instance, it did cover the added expense, and did so very shortly after getting up the program up and running. Now again, just to remind everyone, these visits have a lot of requirements, including a health risk assessment and other elements. So it's not as simple as it looks, but it's very doable. The other thing that we focused early on was transitional care management in concert with the health system, and creating a program that satisfied the TCM claim submission. This also enhanced patient revenue without any additional physician effort. Actually, it made the physician effort much more simplified and easier to proceed, and increased practice revenue, but also made the health system transitional care management program function on a much better plane. So again, unloading the physician, helping the physician do more, in this case with an RN in addition to the NP. Just like the cardiology example, we anticipated quickly hiring a second NP based on the historical volume and perceived demand for services, but we didn't want to jump into that until we knew what the impact of the first NP and the care management piece had on the practice. And then allowing both NPs to expand their services into managing patients with chronic stable conditions, and maybe someday getting into proactive population health services. So this was going along very well. Everybody was feeling professionally fulfilled. There clearly was enhanced patient access. The wait for new appointments progressively decreased. We didn't get it yet under a month because we needed the second NP to do that, but it did decrease significantly. We enhanced patient services and care coordination and management, and increased practice revenue, which outperformed the increase in practice expenses. With that, clearly we also had to add more medical assistants to support the NP, and the RN was very instrumental in training and supervising all the medical assistants. So it was very synergistic throughout. And at the same time, almost nirvana, fulfilled a community and health system, several health system needs all at the same time. So, not everyone will work out quite this well and be that, have as great of a fit as these cases had. But clearly, these are doable and have positive outcomes. So, what's the bottom line? I think it's inevitable that looking at the future and provider supply and the evolving care delivery model changes, it's inevitable we're going to need to increase utilization of NPPs in direct patient care to meet demand, not just in primary care but in other specialties as well. The NPP utilization must be at a maximum of capabilities and licensure, and investing in expanding those capabilities, additional training and additional expertise to maximize the impact and expanded capabilities for the practice. Just adding NPPs without having a plan to utilize them at the maximum of their capabilities just will not work, and you will not achieve the benefits that we've talked about today. Hopefully you've seen that incorporating NPPs in the practices offer a number of advantages, such as enhanced patient access, an expanded scope of services, and positive practice revenue for the investment made. So if you haven't done so already, the time is right to initiate or expand assimilation of NPPs and practices. Get on the bandwagon and plan for the future. So with that, we'll go ahead and pause for questions. Again, they can be submitted straight through the program on the right of your screen. And let's see if we have any. So one question: in the ortho PA example, who submits the E&M charge for the office encounters, physician or PA? Yeah, that's a great question. And depending on how it's set up, you can, as long as you meet the requirements of physician documentation and involvement, you can submit under the supervising physician if the physician is seeing each patient. In the ortho PA example, we were able to do, the organization desired to do that and try to make sure that all of the requirements were met in order to do so. We would often recommend just directly billing for the PA or NP especially as you get into the primary care environment. This also allows you to track things more directly like cost, productivity, and other measures of care. In tracking productivity, if you're billing under the surgeon, as this group did, then we did team productivity, or recommended that they do team productivity measures, and so that the whole team's production and the whole team's revenue and expense were considered, as opposed to having things roll up and just the orthopedic surgeon receive all the credit and all the benefits and all the bonuses, etc. So there was a lot of team-based incentives, a lot of team-based accounting and that type of thing, just based on the billing. If the NPPs are directly billing for the care they directly provide, that allows more individual metrics and determinations. All right, let's see if there are other questions. I think that's the only one. All right, so with that, finishing a little bit earlier than anticipated, but thank you for participating in today's webinar. We invite you to contact us directly if you'd like to discuss anything related to this presentation in further detail, or you can visit our website at www.hsgadvisors.com. This webinar will be posted on our website by Tuesday, the 26th, for on-demand viewing, and we will email you a link when that is up and running. We hope that you found today's presentation of value and will join us for future webinar events. Again, thank you very much, and have a great day. Take care now. Bye-bye.